So the title, I don't think there's going to be any bad or any ugly, but we will see what people's opinions are later on. For anybody who doesn't know me, I'm Rob NICOLSON. I'm a psychiatrist at Western University and the chair of the Developmental Disabilities Program. And in terms of my talk today, I have two theoretical conflicts of interest. Ontario Brain Institute is a publicly funded organization, so it's not with any for-profit organization. Maplate Therapeutics, I'm involved in the clinical trial of a medicine of theirs, but we won't be talking about it, so it has no impact on my presentation today. So I think what I had wanted to do today was talk a little bit about sort of with where pharmacology and autism is going and where clinical trials are going. That at this point in time, most of our treatments, in fact, all of our treatments really are directed towards interfering behaviors in autism as opposed to autism itself. But there is some movement towards trying to trying to address the underlying problems. But there are some problems that I see with that in terms of the theoretical underpinnings, I suppose. And that's what I also would like to talk about later on and how we sort of perhaps address those. So currently there are, there are no treatments for autism spectrum disorder specifically. And I think I could argue reasonably that there are no treatments for any psychiatric illness at all, that we can treat the symptoms, but we can't treat the underlying problems, in part because we don't know what the underlying problems are in terms of biology. And so with autism and the same with intellectual disabilities, really treatment, at least from a pharmacological perspective, are aimed at reduction of behaviors which interfere with the individual's daily functioning. So I think the most important treatments really are things like education, speech and language therapy, occupational therapy, behavioral intervention, stuff like social skills training. But if people's behavior is such that they can't participate in those things because of aggressive behavior or self-injurious behavior or hyperactivity or something like that, then that really limits their ability to benefit from those things. So I think the role of medication really should be to enhance other treatments, enhance and facilitate other more important treatments. So it's to make people more available for learning and to be able to use the skills that they've learned in a more functional manner. But again, these are really all aimed at addressing the behavior problems that people with autism have. They're not aimed at treating autism itself. And so if we look, this is from a few years ago, I think it was in Journal Pediatrics, and it was based on a large HMO in the United States. At the time, they had a sample of 60,000 children with a diagnosis of autism in this massive HMO in the States. And the authors just looked to see how many people were taking psychotropic medicine of one kind or another. And overall, we could see that 56% were taking at least one medicine, and more than 10% were taking at least 3 medicines. And where that becomes concerning for me for many reasons. One is that if we look at people under the age of 2, Jason, can people see my cursor?
Yes.
Okay, so if we look here at this row here, which is people under the age of 2, that 18% of people under the age of 2 were taking medicine with diagnosis of autism, were taking some kind of psychotropic medication, and 0.1%, which is not many, but it's still far too many, were actually taking more than 3 psychotropic medications. And the only reasonable explanation I have for that personally is under the category of mood stabilizers, since we sometimes think of anticonvulsants as mood stabilizers, whether some people might have thought that or viewed an anticonvulsant as a psychotropic and included it there for people with epilepsy. Otherwise, I can't think of a good reason for somebody at that age to be taking any psychotropic medication. So we can see, though, as people get older, the rate of medication use gets higher and higher. So almost 3/4 in people 18 and over. And then it's a study with older terminology, but if people with intellectual disabilities, again, the more severe the intellectual disability, the greater the rate of medication use. Unfortunately, given that there is medication is used pretty widely then in people with autism, it would be nice to be able to say that there's a good base of evidence for that. Unfortunately, that is not really the case. So just last night, I went into PubMed and I just typed in autism and treatment. And from that, I think there's about 28,000 studies that have been published. Now, many of those are behavioral treatments or speech and language treatments, so not just medication, but a wide range. If we add the term drug to that, a medication, is about 5,000 studies, so still a lot. We then add in the term placebo. It is about, I think, 600 or 700 at the most. And many of those are studies done in animal models of autism, or their review papers, or multiple publications coming from the same study. So although medicines are used widely, the actual evidence base for them is thin at best. And that, I think, creates all kinds of problems, because we're working mostly with expert opinion, which is fine, but it's not a substitute for good clinical trials. So I think the best example of how autism medication is used in autism is really with aggressive behavior. So again, it's an interfering behavior. It's not necessarily part of autism, but it's commonly seen in people with autism spectrum disorder. And aggression, and by aggression I mean, I guess, unwanted physical contact towards oneself or towards others, or towards property destruction, or property destruction, is a common problem in people with developmental disabilities and autism, and almost certainly is the most common cause, the most common reason that medicines are started in this population. And a lot of the time, I think I can write part of a consultation report without even seeing patients around aggression, because it's often due to the same thing. So, and at one point in time, I thought I had come up with this wonderful model, and I'd created it myself, and it was really brilliant, only to realize that psychologists had written the same thing about 100 years before I did. So it wasn't quite as spectacular as I thought. But what often seems to happen is a lot of the aggressive or self-injurious behavior we see is often precipitated by what I would call frustration. I think other people call it frustrative non-reward. So people not getting what they want, or things not going the way things would like. And for all of us, that can be a bit annoying if I ask somebody for something and they say no. But I think the added problem then is really poor emotional regulation and poor impulse control. So people getting really frustrated by something not going the way they would like, and then reacting without thinking it through. And so just poor impulse control. And so commonly what parents say is things like that trigger it are things like being told no, having to wait for something, having things taken away. Oftentimes the internet going out or the Wi-Fi going out. I see people who get really worked up if they're playing a game and they lose, things like that. And so often people get a diagnosis of oppositional defiant disorder or conduct disorder, but really I think it's much better thought of as an impulse control problem. And obviously this has a huge developmental component. So 2-year-old children are almost certainly the most aggressive people on the face of the earth. They solve a lot of their problems just by hitting other people. But nobody gets hurt because they're 2. But if you have somebody who is 15 years old and developmentally functions like a 3 or 4-year-old, then they're going to behave like a 3 or 4-year-old, unfortunately. And that's when it becomes a problem. If they have poor impulse control and are easily frustrated, aggression in those people becomes a real problem, because they're much bigger and stronger than other people are. So, I think my mind, and I think evidence supports this, the most effective medicines for treating impulsive aggressive behavior in autism are antipsychotics, medicines we normally use to treat schizophrenia. And there's fairly good evidence for effectiveness in a number of medications from randomized double-blind trials, with aripiprazole or Abilify, haloperidol, lurasidone, which is Latuda, olanzapine, which is Zyprexa, and then risperidone. And they've all been shown to be better than placebo for reducing aggressive behavior. And there was a series of studies published about 15 years ago now on risperidone that I think really were well done and sort of show how these things can be done and what kind of evidence we have. So in this study, which was published, the authors were a group called the RUP unit, which were the research units in pediatric psychopharmacology. And there was 7 or 8 universities in the United States. And they recruited patients with a diagnosis of autism and who had significant problems with impulsive aggressive behavior. And they either received placebo for 8 weeks or risperidone. And the authors didn't know what people were taking, and the parents didn't either, so it was double blind. And you can see the average dose of risperidone that people were taking was a little under 2 milligrams. But we could see that the aggressive behavior was reduced after 8 weeks by about 50%, according to rating scales filled out by parents and caregivers. And I think, I've come to realize it's not just the frequency or the intensity of aggressive behavior, it's what the impact on a person's life is. So how much it interferes with their life. Are they able to go out and do things in the community? Are they able to attend school full-time? Things like that. And so a 50% reduction in aggression, it's still there, it's not gone away, but oftentimes it's enough to make a difference in somebody's life that they're now able to participate in activities they couldn't otherwise do. But generally, if parents come to see me about medication, they don't say, oh, how much of an improvement there's going to be. Typically, people just want to know, is their behavior going to be better or not? And so instead of looking at the amount of improvement, if we just look at how many people were rated as being either much better or very much better by their parents after 8 weeks, we can see that people taking risperidone, it was a little under 75%, whereas on placebo, it was about 15%. And in psychiatry, that difference is huge. You really don't see that kind of difference except with stimulants, certainly not with any other medication class. That's a huge, huge difference. What the authors then did, they said, okay, so we know the medicine works after 8 weeks, but maybe that's just a bit of sedation or something like that. So does that persist after 8 weeks, or does that benefit go away? And so they then added on an open label study, so everybody knew what the patients were getting. And what they found was that after another 16 weeks, that essentially their score didn't change at all for aggressive behavior. So it went up and down a bit, but within sort of confidence intervals. And ultimately, so this is after people had already been on risperidone. That's why the scores don't go down. But we can see that the benefit was maintained at least for another 4 months past the original 8 weeks, which is nice to see. The final thing the authors then did, they said, okay, so we know that it helps people. What happens if we take it away? Are the benefits maintained or do they go away? And so what they did was they had a small sample of subjects, 32, I think, and 16 of them either continued to take risperidone or they had their risperidone gradually replaced by placebo. So it was a placebo substitution study, essentially. And what they found, and this is I'm going to sound like I know something about statistics, I think it's a Cox hazard regression curve. But basically what the orange line shows you is that after a period of time, how many people were still taking the either risperidone or medication, and how many people had dropped out. And we can see that in the people taking risperidone in the purple, that the vast majority of them continued to take the medicine throughout, and really they didn't drop out of the study. On the other hand, people on placebo, we can see over time, more and more of them dropped out because of the fact that their behavior was getting worse and they weren't able to continue in the study. And so you can see that then by taking the medicine away, things reverted to where they were. Now, it was only after 24 weeks. So, it wasn't a particularly long period of time, probably not long enough, but obviously taking it away caused problems. It's a very small sample size, only 16 in each group, because the ethics boards at the universities involved said that it really was inappropriate to continue, given that it was clear that taking the medicine away caused harm to people. And so the study was very small and then ended at that point. So I think this is a really nice sort of series of studies showing that when it comes to reducing interfering behaviors, that risperidone helps to reduce them and the benefit is maintained. But when the medicine is stopped, it goes away, unfortunately. And so it's really a nice, really thorough sort of series of studies looking at from starting it to stopping it. The only study that I know of that has looked at the question of whether antipsychotics help over a longer period of time is with aripiprazole. And so this curve was based on participants after they had been in a double-blind study of aripiprazole or Abilify. So at week 0, that was at the end of the double-blind phase. And so these are all people who had been on Abilify, and they had shown improvement. And then they continued on for another year in an open label fashion. And you can see that essentially their scores for aggression and irritability didn't change at all. They continued to be around, they didn't go up and didn't go down. So it seems that the initial improvement is within the first few months, and then it's sort of maintained after that on average. So, and there aren't a lot of longer term studies like this. It's nice to see that the benefits were maintained, although it wasn't done in a double-blind manner. All right, so that's, fine and dandy, but ultimately I think our goal has to be to try and reduce some of the core symptoms of autism. I don't want to say to treat autism itself, because that is a controversial statement, I guess, among some groups of people. I think what we really want is for people to be able to function at their best possible level. So there have been several studies that have been attempted trying to address the core symptoms of autism, not just the interfering behaviors. And so that's what I want to turn to now, because I think that's more the meat of what I want to talk about. With the increasing prevalence of autism, interest in developing treatments for the core symptoms has increased among a variety of groups, including drug companies. And by the core symptoms, I'm really talking about some of the social communication deficits. So the A criteria, the lack of appropriate peer relationships, the lack of nonverbal communication, and the reduction in social and emotional reciprocity, but also the repetitive behaviors, so the motor stereotypies and the repetitive language and repetitive behavior, and then the sensory impairments. So trying, in this case, not just to address the sort of interfering behaviors, but actually the core symptoms themselves. And so, the first study was with a medicine that I want to talk about called Riluzole. And so it has been proposed that autism is due to an imbalance of excitation and inhibition. And so glutamate is the most abundant excitatory neurotransmitter in the brain. And my hunch would be that it's involved at some level in every psychiatric illness. But excesses of glutamate are thought to be involved in autism for a variety of reasons, perhaps the sensory overload, and also with seizures in some people as well. And so there are several lines of evidence that suggest that abnormalities of glutamate may be involved. And so Riluzole is a glutamatergic modulator. And so it was originally created for people with ALS, or amyotrophic lateral sclerosis, or Lou Gehrig's disease. But because glutamate is probably involved in so many different conditions, there's been a lot of interest in other psychiatric disorders. So I think it's been tried in obsessive compulsive disorder. It's been used in Tourette syndrome, I believe. And there are a few studies initially suggesting that it might be beneficial in autism as well. They're small, they're open label, so they weren't blinded. And so that's what myself and the group of people I work with, we wanted to investigate that. So we did a study of Riluzole in children and adolescents with autism spectrum disorder. And we can see that sort of the randomization seemed to do fairly well in terms of making sure the groups were pretty similar. So they were very similar in terms of age, in terms of male to female ratio. Perhaps more in the Riluzole group were Caucasian, but it wasn't a significant difference. And people taking Riluzole also had a slightly higher IQ, but because of the wide standard deviation, the difference was not statistically significant. And so patients either received tablets containing either Riluzole or placebo, and everybody started taking Riluzole 50 milligrams a day. And after a couple of weeks, people 12 and over were, the dose was increased to 50 milligrams twice daily. And people were seen every 2 weeks from baseline through week 12. And this, was one of those studies that really reminded me about how difficult clinical trials are to do, but also for families. And certainly there is a selection bias in terms of who participates. So you'll have to come in regularly. They have to be able to get blood taken regularly. They have to be able to fill out rating scales and a variety of things like that, which is not always easy, especially to commit to coming in every couple of weeks for 3 months. And so we completed a variety of efficacy measures to look at the benefits. So clinical global impression is just asked, is somebody better or not? Yes or no? Aberrant behavior checklist is widely used in autism, but there is one subscale. It's called the lethargy subscale. I don't know why, but it's thought to reflect social withdrawal. The Children's Yale Brown Obsessive Compulsive Scale is used to look at ritualistic behavior. And then we also looked at anxiety and repetitive behavior. We also did safety measures every couple of weeks. So Riluzole has been associated with increased liver enzymes and liver abnormalities. So we had to get liver function tests done regularly, as well as kidney and just a complete blood count. And then we also monitored side effects using a standardized form called the Safety Monitoring Uniform Research Form, which has one of the great all-time, I think, acronyms of SMRF. It is not printed on blue paper, though. So In terms of results, we recruited 58 subjects across 3 sites. So 2 people in each group, the riluzole group and the placebo group, withdrew. 1 in each group because of lack of efficacy, so people, they were getting worse, and 1 in each group because of side effects. And in terms of safety, that riluzole was well tolerated, apart from the 2 people who dropped out with side effects. In general, there was no significant difference in overall rates of adverse effects. There was no effect on heart rate or blood pressure. And there was a slight elevation in ALT, in 2 liver enzymes, but it was really clinically insignificant and not meaningful in any kind of way. So it was obviously safe. It was generally well tolerated, which is important to know, but I guess the real question is, was it helpful to people? Oh, sorry. See, the other thing is that was different from many medicines we use in psychiatry is that weight actually didn't change in people taking riluzole. And there may have been a very weak trend towards actually people gaining less weight on riluzole than on placebo. But again, it's not significantly different. But given that most medicines we use cause people to weight gain, it's noteworthy. So in terms of the scales we actually used, so the ABC, or the Aberrant Behavior Checklist, the lethargy scale, looks at social withdrawal or social difficulties, and really there was no clinically significant difference there at all. However, in terms of ritualistic behavior and other repetitive behaviors, there was again a trend towards a greater increase in people taking riluzole, but it didn't reach the level of statistical significance. And we can see that in sort of these graphs. So I think over on the far left here, you can see the lethargy scale. Really, that certainly people on riluzole showed more of an improvement, but it was not statistically significant because of the wide error bars. And with the ritualistic behavior with the Y box and then repetitive behavior total score, that certainly there seemed to be more of a difference, particularly with the repetitive behavior score, but didn't reach significance. And I'll come back to that in a while, why it didn't. But there's certainly some suggestion that with time it might have reached that level. So in terms of the change in interfering behaviors, we actually saw an improvement across the board, really. So people taking riluzole showed a reduction in aggressive behavior that was significantly greater than people taking placebo. And also in hyperactivity, there was a greater reduction in people taking riluzole than in placebo as well. Finally, the Spence Children's Anxiety Scale looks at anxiety, and there was again a strong, a trend towards a greater improvement in people taking riluzole, but it didn't reach the level of significance. So certainly we saw an improvement in aggressive behavior and hyperactivity in the riluzole group more than in the placebo group. So, and we can see that here as well, that they really, both the irritability and the hyperactivity, you can see how they really separate over time with a greater improvement in the people taking riluzole. So, in terms of conclusions, that it was well tolerated with no differences in adverse effects, which is great, especially the lack of weight gain. That in looking at core symptoms, there was no significant difference statistically, but there was statistically significant reduction in interfering behaviors. However, I think if we look back at some of the graphs here, especially for the repetitive behavior perhaps, but also the social, the lethargy, the social withdrawal, certainly there seemed to be a trend towards improvement. And, it was a relatively small study with only 29 subjects in each group. And also it was relatively short. So if we had continued to study for longer or at a larger sample size, we might have reached statistical significance. And we didn't, but we might have. And so ultimately our conclusion was that it might be worthwhile for other sort of larger and longer term studies to look into the possibility of riluzole in autism. The problems with riluzole, though, I think really are a few of them. One, requires relatively frequent blood work, which in this population can be a real problem. Getting blood is not always easy from people. And the other issue is that it's also very expensive and may not be covered by insurance companies. So certainly there were benefits, but the practical aspects of it may really limit its use in people with autism. So the other study that we were involved in that I just want to talk about was a medicine called tidaglutide. And it is a medicine, well, I suppose in search of an indication. So it's been tried in a lot of different things with limited benefits. And in fact, the company that provided the medicine for this study, originally the medicine had been tried in Fragile X syndrome. And I think there was improvement with it in some of the features of Fragile X, but not enough for them to go forward in terms of marketing it. And so then this other company bought it out. And then that's where we got it from for this trial. GSK3 beta, which I wouldn't pretend to know anything about, but it's an enzyme that's involved in the neurodevelopmental process, including neurogenesis, so making neurons, neuronal migration during brain development, and axon growth as well. So it's involved in all sorts of things. And it's also thought to be important in regulating inflammation and inflammatory responses. And there have been theories about autism being related to abnormal inflammation. And it also seems to have a role in NMDA, which is a glutamate receptor plasticity in the brain. So it's involved in all sorts of things in the brain. For those who are interested, this is what the molecule looks like. I can't say anything about it, really. And in a nice, simple graph, I say jokingly, of course, that it also is it involves in all kinds of chemical processes in the brain. And so it works on all sorts it's involved in all sorts of things and in all sorts of areas. And so it's not surprising it may be helpful in neuropsychiatric illnesses as well. So, other evidence, though, for its use in autism. So not that we use lithium, but so lithium is a GSK3 beta inhibitor. And it's thought that this enzyme may also be related to schizophrenia and anxiety disorders. So I would defer to anything that Suzanne Schmidt says about knock-in mice, but basically, so knock-out mice are mice where you can remove a gene through, well, I don't know how, but I guess breeding in part, and knock-in is the opposite. You can provide, I guess, extra of the enzyme. And what they found was that mice who had more of the GSK3 beta had abnormal social preferences. They just behaved, mice are generally very social animals. And so they behaved very differently when they had excessive amounts or excessive activity of that enzyme. But on the other hand, deleting the GSK3 beta in the mouse forebrain actually led to some reduction in anxiety, mouse model of anxiety, and also more pro-social behavior. So there's some evidence from animal and very basic science models or preclinical models that GSK3 beta might have some implications for autism. And that's sort of what motivated this study. Tidaglutide is a potent and irreversible inhibitor of GSK3 beta. So as I said, mentioned earlier, it was involved in studies of Fragile X, but also Alzheimer's disease and progressive supranuclear palsy, although the latter two were really equivocal. But because of the possibility of it helping in mouse models of autism, we wanted to study it in humans. And so really the goal of the study was to look at the safety and tolerability of it in humans and to look at its effect on core symptoms of autism. And so, again, with the same 3 centers, we recruited participants to participate in a 12-week randomized study. And at this point, because it was later on, again, all of them met DSM-5 criteria and had a mental age of at least 18 months. And as before, within each center, subjects were assigned to receive either tidaglutide or placebo. So it was divided. So it was across centers, but also within. And so participants received, came in a powder which had to be dissolved in water. And it was a bit difficult to use because it had to be given at a certain time before or eating. And from what I was told, the medicine did not taste particularly good. So everybody started taking 400 milligrams daily, and it was gradually increased depending upon weight up to 1,000 milligrams daily. And like in our Really Is All study, people were seen every 2 weeks from baseline through week 12. And we had the exact same, more or less the exact same measures of adaptive functioning, of efficacy, I mean. And in particular, we added in the Vineland. So the Vineland is a measure of adaptive behavior that's widely used in autism and other developmental disorders. And it just looks at a person's functioning and how they do in life, broken down into communication, motor behavior, and socialization. And we did the same measures in terms of safety. So across the 3 sites, we recruited 83 participants. And in basic demographic measures, as we'll come to in a second, there was no significant difference. So the groups are pretty similar. And 2 subjects withdrew, 1 in each group, because of a lack of efficacy and a lack of improvement or worsening in symptoms. So we can see here that 41 people received the titaglutide and 42 got placebo. And again, the ages are very similar. Their male to female ratio was very similar, as was their intelligence level, as measured by an IQ test. And so they were pretty well matched. Okay, so again, as with the riluzole, it was very well tolerated. There were no significant adverse effects that were regularly attributable to medication, and there was no difference in the rates of adverse effects at all. There were also no difference, importantly, in weight, blood pressure, or heart rate. So again, it was safe and well tolerated, although didn't taste good, and I wonder if that would cause problems long term. So in terms of the social withdrawal scale, so the lethargy scale of the aberrant behavior checklist, we see that there was a comparing placebo and the titaglutide is what's here called the AMO-02. And you can see that with titaglutide, there was a greater reduction in impairment, greater reduction in the score of for titaglutide. And on the right-hand side, we can sort of see what the percentage change. So we reduced by about 40% in people with on titaglutide, as opposed to a little more than 10 in people on placebo. And the p-value, so it didn't quite reach significance. Statistically, it was very close. And the effect size, which just looks at how strong the difference is, I suppose, looking at sample size and other things, was 0.4, which isn't bad for a psychiatric illness or medication. So certainly that's nice to see. With repetitive behavior, again, similar, and you can see actually that the change overall, that initially for the first month or so, there was no change, and then they really started to separate. And so again, after 12 weeks, the difference was didn't reach statistical significance, but was getting there. It was close. And then finally, looking at the Vineland Adaptive Behavior Scale, and particularly the socialization part of the Vineland, we can also see that there were improvements there, greater with the titaglutide. So in particularly the socialization part, we can see that people taking titaglutide, again, had a trend towards a greater improvement. Now it's, 3.5 points. And to be honest with you, I'm not exactly sure how much that means. Is that meaningful? But certainly there was a trend towards statistical significance in terms of the improvement. All right, I don't know why I have this here. So it says riluzole, it should say titaglutide. My apologies for that. But again, it was tolerated. There were no differences, adverse effects. There was no significant differences from placebo. But there's certainly the trend towards improvement in repetitive behavior and social withdrawal, and also overall socialization functioning was fairly strong, and suggests again that perhaps a larger sample size and longer studies may find a difference with that. And I actually believe that I was talking to a cardiologist at Western a few years ago, and they actually had an interest in looking at titaglutide. Also, I don't know what happened with it, but it seems to be a medicine that different groups looking at different parts of the body are interested in. So from these 2 studies, we have, some evidence that medicine may address some of the core symptoms of autism. But, I think personally, there are some really significant problems with clinical trials in autism. And I think that if we don't address those, it's going to make everything more difficult. The first really is, can medication change social functioning? And I'm not convinced that it can, because it's not just medication, but also people's experiences and the fact that people, generally human beings, are very social creatures. And so our brains develop in a certain way based upon our input and what we do. But if people with autism don't have that same drive early on, then sure, theoretically, medicine may change that when they're older, but all that developmental time has already passed. And so really, what is it possible to make up for last time? And I don't think so in terms of development personally. And so it raises a question in my mind of what it would actually mean to show an improvement and who these people would then be. I think, though, apart from that, there are a few issues. So certainly one of them is going to be the diagnosis of autism, that we know that it is diagnosed very differently in different places and using, well, theoretically similar criteria. But it's, I think, unless we have a good sense of what the actual phenotype is, and unless we have a sense of what autism actually is, if we include in studies people who don't have autism, then our results are really not going to be what we want. That we may find about kids with problems, but they may not necessarily about autism at all. And the other part, when we think about the heterogeneity of the phenotype, is around intellectual disability. So in these studies, do we include people with intellectual disabilities or not? And is it harder to show improvement in those people in social functioning or not? And I've come to wonder if perhaps theoretically, if it's possible to address the social core symptoms in autism, I wonder, though, in people with more severe intellectual disabilities, if it's better to focus on just what the interfering symptoms are, because that's really what's going to interfere with a person's ability to function. And until we get beyond the phenotype and the heterogeneity, I think everything else is secondary, really. So the other issue becomes duration of studies, and this is where it's hard to get people to participate at times. That even doing a study for 12 weeks. Required a lot of visits on the part of families and a fair amount of blood work, which wasn't easy. That a couple of companies now so we've been involved in 2 studies by pharmaceutical companies, and one of them, I think, is about 4 months, which creates problems. And then they actually have an open label phase afterwards. So after people have completed the study, they then have the opportunity to know for sure that they were taking the medicine for a year afterwards. But again, it requires fairly frequent visits to the hospital, which can be time consuming and interfere with other things. But also, in order to see real improvement, I assume that 12 weeks may not be long enough to see an improvement in social functioning. And if we think about the Vineland, so the one measure that we used in the NICOLSON study, it actually asks about how a person has been over the last 6 months. So really, whether it can even detect differences in shorter periods of time is debatable. I think the third issue is treatment targets. So as I mentioned, is it realistic to even try to address the social withdrawal, or if we can, how do we do that? But also with the repetitive behaviors and the repetitive language and things, are they really amenable to drug treatment? And I'm not sure, especially with the abnormal language development that we see in people with autism. I think we also need much better definitions of what social impairments are and what repetitive behaviors are, because otherwise it's a real wide range of things that we're aiming for. The other thing, and this I personally think is a huge problem, is the validity of the measures that we're using. So are they really useful? So I think one problem we have across all of psychiatry is that our rating scales tend to look at the symptoms of a condition, but not necessarily the overall functioning of how somebody's doing. So for example, I think it's pretty good evidence, pretty solid evidence really, that stimulants can reduce the symptoms of ADHD. I think there's no doubt about that, frankly. But very few studies have actually found improvements in academic achievement in people taking stimulants, which doesn't make a lot of sense to me. But maybe we're missing a bigger picture than just looking at the symptoms. And same with, so as I mentioned, though, with autism, how do we really measure social functioning? That I think one of the problems with the diagnosis of autism is that we can all recognize social difficulties, but actually defining them is much, much harder, and especially defining them in an operational way that we can then apply to others. So, and the same with repetitive behaviors. So what are repetitive behaviors? How do we measure them? How do we assess them? Is it by frequency or by intensity? And the same with language. So I just think that a lot of the measures that we have are really inadequate, frankly, at this point in time. And I think that, I think it was Autism Speaks in the United States, I'm not sure, a couple of years ago, it put out a call for applications for a grant competition looking at developing better measures in people with autism for treatment studies. And finally, as I say, that, and this goes back to the limit, even the current measures we have are based, first of all, purely on parental observation. So really, we're depending upon parents' observations and what they see and what they don't in their children, but they obviously can't understand why their children may be socially withdrawn or not interacting with people, but also, how do we actually measure the frequency of stereotypies and things like that? So do we measure each episode or each time it happens, or the number of times, sort of a number of episodes in a day, or is it a general gestalt? And there's no real answer to that. And it is problematic because, unless we have good measures, our studies are not going to be particularly helpful. So I think personally, until we address these things, that even measuring aggression is not as straightforward as it might seem sometimes, and there aren't a lot of great measures for it. But I think until we can improve these, sort of address some of these concerns, finding medicines that are effective and tolerable in people with autism spectrum disorder may be difficult. And yeah, I have a lot of concerns and questions about what's going to happen in the future with these. And so I will stop there. I could, I suppose, ramble on much longer, but I won't. And so we have lots and lots of time for questions and answers, so normally, Jason, under participants, I think it is, sorry. So in the past, we've used the raise hands function. I actually don't see it there anywhere. Is it available, Jason?
Yeah, it is.
Okay.
Yeah, you can just hit the react button and then you can raise your hand, or there's the Q&A option too.
Okay. So if I hit the react button, what happens? Oh, well, so Dr. Schmidt thankfully showed us that it works. So there we go. So Suzanne, if you want to unmute yourself. And I don't know what happened there because you disappeared. Oh, completely. So there you are. Yeah, you should be good to go there, Suzanne. Although, having said it.
Hello?
Oh, there you are.
Okay.
Hey, Suzanne, how are you?
I'm good. How are you?
I'm well, thank you. Good to hear your voice.
Long time no see.
Indeed, too long.
And well, thank you for that talk. I think that was really interesting, especially for someone like me who is an animal researcher. It's always good to hear, the things you face in the clinic and about these clinical trials, because that is not what we usually normally read, the type of literature that we read. I would have a lot of questions, but I maybe want to reduce it to some comments. So I agree with a lot of things that you have said. And looking at this clinical trial, so from an animal perspective, we always have that notion that autism is probably not one disorder. So if we look at these different genes that are implicated somehow in autism, I think there's agreement that many of them are upstream or downstream the same molecular pathway, but at the end we have maybe 5 or 10 different molecular pathways that are impacted in one or the other person. So that ASD maybe in reality is 5 to 10 different disorders if we define it biologically by the cause. And so when I look at these clinical trials, what I see is often a relatively moderate effect, but a huge variability. And so one question I have, and probably you have looked at that, is the data even normally distributed? Or are there individuals where the drug has a lot of impact and others where it has no impact? Because they might actually have different molecular pathways that do not work and where the drug actually does something to interfere with it or not. And it is difficult, of course, because I appreciate that you might not know, there are causes for autism, which we know don't know in most cases. And then the placebo effect comes on top of it. And then the issues with what are good measures. I don't even want to say parent questionnaires, but how precise are your measurements? And so that all comes on top of it. And so even if you would have 2 discrete groups, a group where it works and a group where it doesn't work, and maybe an intermediate group where it works a little bit, depending on what their causes are, what is not working properly in terms of molecular pathways, and then you put the placebo effect on top, and it just blurs all these lines, and then, you know, you get this big variability, and maybe not distinct groups, but just, yeah, this variability that you see. So to what extent do you have the genetic footprint of these, or the sequences of these people that you test in the clinical trials? Because my idea is that probably, you know, if we would have the means, and often we don't have that, treatment would probably need something like a personal medicine approach, where you actually really try to figure out where is the cause and how do we actually treat this specific pathway that is impacted in a person.
So I think those are great points, Suzanne. So first of all, I think across psychiatry, we don't really have any ability to personalize treatment. That there have been some labs have pharmacogenetic testing, but I think it's still in its infancy, really. And when you talk about the placebo effect, it's really interesting because it's almost certainly going to be in the parents, people taking it, not in the patients themselves. And so it's a different kind of, it's almost like a vicarious placebo effect. But one problem, and this has been shown in ADHD also. So Catherine Lord, who is, I think in New York now, but so she had published a study a few years ago showing that if you, and I think it was actually almost an accidental finding, because they gave parents some rating scales on their children with autism. They then gave them a few weeks later, a month later, and found that they had all shown improvements, even though nothing had changed in the interim. And I think, and the same has been shown in ADHD, and that really is a problem in terms of what the ultimate results are. And so the current trial that we're doing with MapLight Therapeutics, what they actually have is a 2-week single-blind placebo phase. So everybody gets placebo at the beginning, and then and if people show a significant improvement on the placebo, then they are excluded from the larger trial itself. And so we have genotyping on all the subjects. And I know that there was a plan to look at it with in the Realizol study and look at certain glutamate genes. I'm not sure exactly what happened with that or what the results are, to be honest with you. And in terms, the assumption we have is that the results are normally distributed. And the statistician we are working with is fairly, let's see, conscientious, I will say. How's that? That he's very meticulous. And so I think if he felt it wasn't normally distributed, he wouldn't run any stats. The other problem we have run into, I don't think recently, but in past days, is having two people like brothers or siblings in the same clinical trial. So I think with the statistics, the assumption is that all the individuals are independent of each other. And if you have siblings, they're obviously not. And so, I mean, there are a lot of those very mundane kind of problems, but that can have a huge impact on outcomes. And I think one way to get around that is just to have really, really large clinical trials. So we were involved with Roche Pharmaceuticals a few years ago with a trial, and they were doing a study worldwide with this medicine, balovaptan. And I forget what their goal for enrollment was. I think it was several hundred anyway. But even that, it was partway through the study, they did an analysis to see if there was any chance that they would meet their outcome goals. And there wasn't, so it was actually stopped prematurely because it was clearly not going to be a significant finding. So I think, these things you highlight, they're all huge problems that I think they are common across all of psychiatry, though. And what we run into sometimes in psychiatry is that if you try to remove all of those sort of individual things, then you end up with patients who don't really represent the thing you're interested in. So, for example, a lot of schizophrenia studies, they exclude people with epilepsy, they exclude people with substance use problems, so then really in the long run, are you actually looking at people with schizophrenia, or is it a very small subset of that group? And I think by the nature of even our clinical trials, the fact we had parents who were able to bring their kids every 2 weeks, the fact that kids were able to get blood work done once a month, I mean, that's obviously makes it a subsample of our patients, not the whole group. And so I think these are things that need to be addressed as time goes on.
Yeah, I agree.
And, I didn't talk about our baclofen, Suzanne. Maybe we can do that next time, because I know you've done some stuff with it as well. But let me move on here, if I may. So, Julio, do you want to unmute yourself?
Oh, yes. Can you hear me?
Yep. ¿Cómo estás?
Okay. Good to see you, Rob.
Yep.
So I really enjoyed the talk. Thank you. And keep trying to keep updated with these things. And one thing that when you talk about the glutamatergic agonists or the glutamatergic drugs in general, one thing that is like a red flag for me, you know, that there is a comorbidity between epilepsy and ASD.
Yep.
So in your sample of patients, did you have any patient that had epilepsy and ASD in the sample that you use in your study? And did you use that on exclusion criteria? Is there anything, because one of the things that when you have an increase in glutamate, right? One of the things, the first thing that comes to my mind, well, there is a change in the excitation inhibition balance. And if that thing goes too high, you may just have seizures.
But really it's always a glutamate, and well, I mean, it's not necessarily an antagonist, but yeah, I think it's a modulator, but I think it essentially becomes an antagonist.
Oh, in this case, what you're doing is blocking glutamatergic transmission.
I think it's simply, yeah.
So it has then been used in epilepsy or in other disorders that you have. So you say that it was used in ALS, right?
Yep.
Okay, for blocking glutamatergic transmission.
Hang on, let me just, now that you say that, I'm questioning myself, of course. But let me see here. So so riluzole is a glutamatergic modulator with neuroprotective and plasticity enhancing effects. I think ultimately it's not a pure antagonist, but I think that's what the effect is in the long run.
Okay.
But I mean, to answer the question though, so we excluded people with unstable epilepsy, which I think meant they had to be taking an anticonvulsant and not had seizures in the previous 6 months or something like that. I can't remember the exact criteria, but again, so that is going to remove a certain percentage of people, unfortunately.
But did you do any imaging or any study to look at, or someone has done, where the drug has the main effect? If you do like placebo versus control, in which brain regions or brain circuits you may find some differences?
So we did, and again, I'm not sure the results at this point in time, but it was mostly with structural imaging and then spectroscopy, as well as some functional imaging. But I think really to look and see what parts of the brain the medicine's actually going to, you'd probably have to do PET scans, wouldn't you?
Probably, yeah, yeah.
Which I think in kids would be difficult to do ethically.
Yeah. But thank you.
Oh, thanks, Julio. Good to hear from you. Dr. Balchi, why don't you unmute yourself?
Hello, can you hear me?
Yep.
Okay. Hi, Rob. Thank you very much for the talk. And I just wanted to follow up with what Dr. Schmidt had said, and but in the meantime, you said something that I want to now ask about in terms of the genetics of or the genetic background of people with autism, and maybe the homogeneity or the heterogeneity of it, rather. So I think you said, and at some point I needed to move from the office to the car, so I may have missed it. I think you said somewhere that there was a clinical trial on just people with Fragile X and autism.
No, so with titiglucid, that originally the company, I think that synthesized it, perhaps, I'm not sure if it was the first trial, but they did a study looking at people with Fragile X syndrome. So it had nothing to do with autism at all. It was just around Fragile X. And it was a negative trial, essentially. I think it might have shown slight benefit, but not enough to go forward. But I think there have been, my understanding is there have been several medicines that have been tried in Fragile X now, especially because my understanding again is that the neuronal abnormalities are known now in Fragile X. And so I think there have been several medicines that have been tried with, again, some small success, but not enough to make it worthwhile for the companies to go forward.
I see. No, I just thought that would have been like a nice, clean sample, right? Like people with Fragile X and autism would be what you would call a fairly homogeneous in terms of genetically speaking, a sample of individuals who would technically, respond similarly because they all have the same genetic underpinning, right? But not all people with Fragile X will have autism, but most of them do. So, and I know Dr. Schmidt said, there's maybe 10 different subcategories. Maybe there's even more. But of course, the difficulty is the genetic reasons are rare just by themselves. So it's hard to get that kind of homogeneous group. But then you said, you know, the clinical trials that you were involved in, they were genotyping all the patients. Do you know what they are doing? Like, are they doing like whole exome sequencing on the patients, genotyping them in what way? Just pharmacogenetic stuff, or like all the genes?
Yes. No, I couldn't tell you, to be honest with you, Tuche. I'm not sure. I'd have to look into it.
Mm-hmm.
Because I know that was one of the plans. And so it's with Steve Scherer in Toronto. And one of the plans had been to, you know, look and see among responders, was there any difference? I think probably looking at specific genes would be my guess, or the alleles, but I'm not sure about that, to be honest with you.
Yeah, and if Dr. Scherer is involved, then, you know, I think what we're going towards is that monogenic causes for autism are exceedingly rare. They're there, they're possible, especially in families with recurrence, or kids who are more syndromic, as you know, with other issues going on, like epilepsy, for example. Then you're more likely to find one gene reason. But for the majority of autism, I think we're going towards more like a multigenic or gene environment interaction type of inheritance, meaning that, you know, there's not just one gene. And I think Scherer's group and others are looking into that right now to, you know, genotype them all, quote unquote, to look at many genes at the same time, maybe have like a polygenic risk for something like this, or so it's not a traditional monogenic condition, it looks like.
No, and in fact, so Tuche, one question I've had is, if it is multiple genes interacting with each other, currently available genetic methods, would they be able to detect that?
No, that's what I mean. Yeah. So what we're looking for right now with exome sequencing or our autism ID panels are monogenic causes.
Right.
We're really not set yet to look for this, but it's a theory for also like the more common types of epilepsy, also for schizophrenia. It's been talked about. It's been shown to be true for something like hypercholesterolemia, for example, familial hypercholesterolemia. There is a polygenic risk score that is being developed, but it is very difficult for the reasons that we just talked about, like the heterogeneity is huge, and how to interpret it is very, very problematic right now. But a lot of groups are looking into it, as I know. But no, currently no clinical testing for that.
Yeah, I think that's what I had thought, but until now I had nobody to ask. So thank you. I appreciate that, Tuche. So Ashley, I will come to you in 1 second, but so just first of all, Julio, that Dr. Schmidt had put in the chat, that really is all inhibits glutamate release. So it's not really an antagonist, but it reduces glutamatergic transmission, I suppose. And then there was a question from Dr. Berube about, do you think treating at a younger age would better address connectivity issues and have a better outcome? So that is a fascinating question, Natalie, that, you know, early intervention is sort of the goal for everything, in part because, you know, our brains are plastic at a very young age. And I think somebody who has a great model for that is Nicole Neal, who's in the Faculty of Education at Western School of Education. And she actually does research on early intervention with Down syndrome. And it's a perfect model because theoretically, you're going to know almost 100% of the time before people are born that they have Down syndrome. And if you wanted to, you could almost literally, from the moment they're born, you could start intervening. I don't believe they do that in the delivery room, but, you know, it would be a great model. I think the issue of starting at a younger age, at least today, is I think a lot of parents might be really reluctant to have their kids taking medicine. And there's the problem with the age of diagnosis, you know, that it's at least 3 or 4 for most people. And by then a fair amount of development has already occurred. And the other part will be actually getting medicine into those kids. Although if it's important, parents will figure it out, I think. But I think that it'd be a great idea. And that's where I think looking at studies in younger and younger people will be really fascinating to do. Dr. Galloway, did you still want to ask a question? I don't see you anymore. There you are. Ashley, did you want to ask a question or comment? There you go.
There we go.
Yep. How are things on the left coast?
Option. Hello.
How are things out west?
Busy.
Good.
Very busy.
Like
Very
that.
good. Yeah. So I was just thinking, like, based on like my practice right now and where you were talking, one of the things that comes up a lot in some of the patients and their parents is like they really want me to define for them what is, you know, due to the autism versus what is anxiety, what is OCD, what is ADHD, what is something else. And sometimes it's really hard to like get across to them that, you know, we may never really know. And we can call it whatever we like, but this is the problem that we're facing, and or is it a problem or is it not? And so I find in my practice, we've shifted a lot away from like formal diagnosis of things at times and more just, is this a current concern that we need to try to treat or not? And how can we do that? Just kind of wondering your thoughts on that, or I guess it's not really a question, just more of a comment.
Well, I think across psychiatry, comorbidity, depending upon your perspective, I guess, can be a problem or not a problem at all, right? So if we think of people with Tourette syndrome, that if we really just want to do a brain imaging study of people with Tourette syndrome or something like that, to find people with Tourette syndrome who don't have ADHD or OCD and things is really, really difficult. And they're out there, they're a small number. But even if we can find those people, are they really representative of what Tourette syndrome is, given the high rate of comorbidity? And I think somebody was explaining to me once that comorbidity in psychiatry is different than somebody with diabetes having comorbid asthma or something like that, right? I mean, I think that what we call comorbidity, really people have one problem that happens to manifest itself in multiple different ways. But it really makes it difficult in terms of treatment sometimes to find the target. So even in up until DSM-4, what it said under ADHD was that if people had a diagnosis of autism, they should not also be diagnosed with ADHD, with the idea being that the autism would account for the ADHD. But not everybody with autism is hyperactive, so there must be something different about those people. And the other problem with that is if one purpose of a diagnosis is communication, to not say that somebody has ADHD is problematic. And so that requirement or that exclusionary criteria has now been removed in DSM-5. But I think this becomes a huge issue also, as you say, because should we just be sticking with the interfering behaviors because that's what interferes with people's ability the most, or should we be looking more at the core features? And I don't know if you can, you're not going to find people, well, I think finding people who don't have other problems is going to be a very, very small group.
Yeah, for sure. So I think too, they're certainly not presenting to our clinics. Like those aren't the people that are being referred in.
No, you're right. You're right. I mean, it's not it's often the other behavior problems that are really the main issue that people get referred for treatment to. So that's a very good point.
Yeah.
But you're doing okay?
Oh yeah.
Good. I will talk to you after. Yep. Excellent.
Yeah, absolutely.
Yep. So there's also so Dr. Friedman asked a question here in the Q&A. It just have you used the ICF to evaluate global functioning as one of your evaluative tools in assessing function rather than symptoms? If so, to be honest with you, Clive, I'm not sure what the ICF is. That the measure that we use is the Vineland Adaptive Behavior Scale, and it's widely used across a variety of measures in research in children. But as I say, it's not particularly. It's not. It doesn't have good time resolution. That it asks about the previous 6 months, and it is debatable how useful it is. I mean, I think it's a great measure for autism, but it's not necessarily great for clinical trials. But I don't think there's anything better either, and that's one of the real problems. It is. What is the ICF, Clive? Is it possible for you to type that in somewhere? Well, how about if later on, if you could email me or put it in the chat or something, Clive, I'd be interested in knowing what that measure is, because we're always looking for newer, I don't want to say better, but newer measures, perhaps better. Sorry, International Classification of Health by the World Health Organization. So I guess the ICH. No, but I mean, I'll have to look at it, because is it, from your perspective, is it a useful measure of functioning?
Can you hear me?
Oh, yes. Hi, Clive. How are you?
Hi, Rob. I think it's a very different measure of functioning rather than symptoms. That evaluates the overall domains of health from a very specific, the ICF classification has got very detailed domains that it looks at in terms of intellectual functioning. And it looks really from a perspective of function, overall function, rather than specific symptoms. If I use it to evaluate a kid, I'm not really looking at whether it has decreased their stereotypies, for example, but whether in fact the intervention that I'm using is helping that individual cope with a procedure that I might be doing. For those of you who do not know, I'm a pediatric dentist. So I'm not looking at decreasing symptoms. I'm rather looking at, will this enable this individual to better cope with what I might be doing?
Well, but I suppose that's really the crux of it. I mean, people's ability to cope with life and the stressors of life.
Right.
And the demands of life. You know, I'm not familiar with it, Clive, but I will certainly look in it, because I think that's what we're always looking for, is sort of big picture kind of measures. And in terms of, to figure out, how do we help people to function at their best possible level? Which I think is, in my mind, the goal, not to cure somebody, whatever that would even mean, but just to help people to do the best they possibly can. So, I mean, I will certainly look into that, because it sounds promising.
So thanks very much. Very interesting.
Oh, well, thank you, Clive. Good to hear from you. Okay, so it is now 5:10. If there are any other comments or questions, we can take those. But otherwise, let me just make sure there's nothing there. Okay. So thank you, everybody, for joining us. It was, sorry, to say, so Natalie Brube just added in that, so Natalie does, it works with animal models, and she just wrote here, our mouse model of autism definitely suggests early intervention will be necessary for some aspects and symptoms. And to me, that makes absolute sense. And I think, that development is meant to occur in a sort of longitudinal way, I suppose, and intervening at one point in time later on would be, I'm not sure how useful it would be. And the question becomes, how do we actually identify people at a young enough age so that it's going to be possible? And I think that would be the real difficulty. But I think that's, in a way, Natalie, I think sort of the holy grail, right? How do we identify people and intervene in a way that's meaningful at a point in time, which is going to make a sort of change their developmental trajectory, I suppose, is what we would like. But thank you for that, Natalie. It's really helpful. So thank you again, everybody, for joining us today. I'm glad we're all here. And so before, if everybody could please fill out the evaluations, they just help us in terms of understanding what people are looking for and what people would like in terms of speakers in the future. And Jason Wittes will, if everybody is registered, he will, Jason, we have it for the College of Psychologists?
Yes.
So we could send, and family doctors also, although I don't know if any joined us.
Not for family doctors. No.
Okay, so for people who are require CME credits from the College of Physicians and Surgeons of Ontario, Jason will send out certificates for that, and also for psychologists. But yeah, if people could complete the evaluations, that'd be really helpful. And so our next talk will be on December 11th, and our esteemed colleague, Dr. Schmidt, will be talking about her research and what she's done over time, and has done a lot of really fascinating work. And so we will see everybody on December the 11th at 4 p.m. All right, thanks, everybody, and take care.